We've come from Bradford District Care NHS Foundation Trust to talk about the out-of-hospital multidisciplinary team. My name's Carla. I'm the Service Development Clinical Lead for Community Matrons and Case Managers, and I was the clinical lead for this team. My background is elderly care, and I've been a community matron since 2007 and working for Bradford District Care Trust since then. I've been the clinical lead for both the out-of-hospital multidisciplinary team and for the community matrons and case managers for the past 18 months. And this is Rachael.
My name's Rachael Woodington. I'm community matron and advanced nurse practitioner within Bradford District Care Trust. I have a specialist background of dementia care and elderly care, and I've been in the community now for the past 15 years. Previously worked in acute care in intensive care. And I was part of the out-of-hospital and multidisciplinary team as a clinical coordinator of the team alongside Carla. So in the beginning, the service began because in March 2020, a document was published by the government in response to the COVID-19 pandemic. This document, the COVID-19 Hospital Discharge Service, was to change the way community services supported 95% of patients being discharged early from the acute healthcare providers. Community services were to lead the way, to ensure that patients had a seamless service post-discharge and safe within their own home, with prompt access to both health and social care provisions, working hand in glove with social care. 45% of patients post-discharge would be able to recover within their own home, but only with the support from the health and social care. Alongside this, it was imperative to include therapy services and a large element of case management.
The group that developed this team was made up of many different stakeholders and was developed with a discharge to assess model in mind. The group consisted of managers from the local authority, social workers, community matrons, the clinical lead for community matrons, the adult physical health general manager from the community trust, our trust, secondary care, therapy services and personalised commissioning department. Initially, the conversations were led with individual service needs in mind, each with their own little agenda, and we had to work through that for the common goal, which were our patients during the pandemic. The steering group identified relevant staff who could be redeployed, but those staff needed to be confident in their roles and within their networks to enable the success of the MDT, so they were very senior staff from most services. It was a real benefit to me as the clinical lead to be involved in these primary discussions to then support the team as it evolved. In Bradford's vision, Bradford's vision was to create an MDT team to take referrals for patients from the acute trust who were medically ready for discharge but were still requiring some medical and social care support alongside supporting care homes with ever-growing needs due to the COVID-19 pandemic, with a 2-hour turnaround from referral to contact. So it could be those patients who perhaps were having medication changes and would previously have been kept in the acute wards, having those medications stabilised, but they were coming home optimised rather than, and then we were picking those patients up. The team were to look at multiple issues that might arise from the patient once discharged, alongside the needs that were identified from the acute trust or the care home facility. These included some signposting and advocacy, equipment, medication reviews, some palliative care management, ongoing health, social care packages and looking at their needs, re-enablement, some PPE help and some COVID-19 testing for patients that were being discharged to beds or nursing home beds. Our service was run from 8 till 8, 7 days a week, which was a different kind of sort of community nursing staff because they're used to working within hours. But 8 till 8, 7 days a week, with a professional lead accountable for each patient's case and the seamless coordination of that patient's care. Huddles were twice daily and all professionals from each discipline were present at the huddles. So meeting the team, so we've talked about the steering group. The team now, the out-of-hospital MDT was made up of some social work team leaders, who were very experienced in our area, personalised commissioning nurses or continuing healthcare nurses, some physios and OT input, some community matrons, and we also used it as a developmental exercise for a trainee matron. The community matrons were the coordinators of the huddles each day, and that was because we were used to our system one and of all of our processes that we encouraged the other professionals to join us rather than trying to find a new way of working. And the team was led and managed by myself as the community matron clinical lead. During the development of the team, it was really important for us to provide a virtual environment, one that mirrored being in a room together. So for a cohesive, well-run process, all the team members were invited to get together via MS Teams to practice the huddle processes, to establish relationships, to look at our standard operating procedures, our roles and our responsibilities. And we considered this of utmost importance as all the team members were redeployed from their usual roles. So it was a new way of working in a completely new team.
Service. So following a referral from the acute trust, care home or specialist service, a structured handover was undertaken for each patient. The community matron in charge that day took the clinical lead for coordinating, identifying the reason or reasons for referral, needs to be met, and who those needs were to be met by. Most were met on the same day or within 24 hours following referral by all clinical services involved within the team, meaning that the patient did not have to wait a long period of time for care services, therapy, or a clinical review, when often pre-COVID, there were delays accessing these services due to extremely high demand, thus reducing the number of readmissions to the acute trust for health and social needs, and taking the pressures off care homes during the pandemic, and providing true holistic care to all patients post-discharge. As a team, we were very privileged to have several other services running alongside us that we were able to signpost to if we felt that the patient needed an escalation of care needs and that maybe it was outside our scope of practice. And this was called the Super Rota. This was led by one of the trust doctors and a team of nurse consultants. Again, this allowed us as a team to ensure that the patients were receiving the best standard of care possible whilst remaining within their own home and shielding from COVID-19. To achieve true holistic, seamless care, a patient rarely just has health needs that need to be addressed. Social care needs are in an ever-growing demand due to ageing population and an increase in multiple comorbidities. Alongside this, a global pandemic that very few were prepared for. Without taking a coordinated approach to a patient needs, both health and social, through an MDT viewpoint, care during the pandemic would have been very difficult to coordinate and manage safely. By using the approach of the out-of-hospital multidisciplinary team, we were able to ensure that all needs that were identified were met in a timely, safe, ensuring that the patient was in the correct environment at the right time with the right person, providing and supporting that care need. Thus, again, helping reduce admissions, any trauma for the patient, improving health inequalities, and reducing the impact on families, helping provide the care alongside the professionals. Alongside patients within their own home, it also provided support for staffing issues within care homes that had high COVID-19 outbreaks, supporting with any PPE concerns, and helping provide equipment for patients who were deteriorating or requiring end-of-life care support, and providing support for staff who were struggling with this. It was a true seamless service that provided high quality care through an effective and efficient MDT approach for holistic care.
Achieving collaboration. During the pandemic, many teams and services were developed, and the out-of-hospital MDT was set up during the first wave, and it was set up fairly rapidly, really, within a couple of weeks to meet the needs of the patients. We continued to work closely together once the team was demobilised and agreement was made between all the stakeholders that if required, a pop-up MDT could be mobilised at short notice. This came into effect in the second wave when in our local area care homes hit crisis and large amounts of staff and residents were testing positive for COVID-19, and it became a real issue for the care homes and the staff and the residents in our area. The out-of-hospital MDT was reinstated within 48 hours and team members were back in the team. With this now being on care homes rather than those at home, we included palliative care teams and the COVID home visiting team. So all of the patients in the care homes that required nursing input were seen by our COVID home visiting team rather than our existing district nurse services. Alongside the MDT, we worked with the super rota that Rachel's already mentioned and the digital care hub, and we created processes for all professional groups to follow to support the homes. And we worked with their COVID team, with the care home groups, and with the super rota and the digital care hub. And the team has allowed us to develop wider networks and work alongside the professional groups in a joined up way that previously worked in silo. So for example, within this collaboration, a home could identify that they had some COVID positive patients, and within 24 hours, we would have had the local authority team involved. The super rota would be having daily contact with the care home via technology called InMedicare, and that was done via the digital care hub. So they were involved taking observations virtually every day from the care home staff. We were then contacting the local GP practice to let them know that there'd been an outbreak, or district nursing teams would contact the home, and we just pulled everything together really cohesively so that that home support that it needed.
So, the out of MDT has enabled us to work more closely with our social care providers than we have ever known throughout our careers. It has highlighted many exceptional services and individuals that are available for patients that we often know little about, and the same can surely be said that our social care providers felt the same with the community services. It has offered links to therapy and mental health services that will long continue post-pandemic. By using video links, it's allowed us to put names to faces and become more of a working community, a team rather than individuals and services. When working as a team, the outcome will always be greater than working alone, and especially when trying to cover multiple areas of care, this is only going to benefit the patients. It's allowed us to understand roles, commissioning, referrals into service, and highlighted effective ways of working moving forward. The out-of-hospital MDT has enabled us to work more closely with our social care providers than we have ever known throughout our careers. It has highlighted many exceptional services and individuals that are available for patients that we often knew little about. And the same can surely be said that our social care providers felt the same with the community services. It has offered links to therapy and mental health services that will long continue post-pandemic. By using video links, it's put names to faces and become more of a working community, a team rather than individuals and services as it was previously. When working as a team, the outcome will always be greater than working, especially when trying to cover multiple areas. This is only going to benefit the patients. It's allowed us to understand roles, commissioning, referrals into services, gaps in service, and highlighted effective ways of working moving forward during this difficult time. So what do we see for the future? So it is certainly an evolving change that needs to be met. As previously mentioned, we are aware that there's an ever-growing population with multiple complex needs that need to be addressed with a holistic manner that, as nurses, has always been at the forefront of our delivery. Post-COVID-19, some of the challenges between social care and health will remain prevalent due to funding, staffing, and increasing demands on services again. It is, however, only hopeful that some of the links made during the pandemic will have highlighted the need for more integrated care, for more proactive care, and for us to work closer together without any corporate red tape. Carla has some feedback from the service that we received.
So we got lots of feedback. We did some friends and family testing for every patient that came through our service, and these are just some of the comments. They were there for you when you needed. We needed assurance for things that would happen, and it really helped. The matron was great. very knowledgeable, gave lots of information. Myself and my family were very informed. Another one is better coordination between services to tell what different services has happened. Another one that I particularly like, brilliant, full stop. I like that one. Good, helpful service offered. All people were kind and helpful, including My Care 24. So they were a digital team that worked alongside us. Another one, couldn't have done any better. It was brilliant, and things were sorted out for me. And then we had some feedback from some staff as well, where they said that everybody had been really helpful, staff were very proactive, it was all really good. We didn't have a single negative comment, which is brilliant for us. It was easy to refer. My patient was seen much sooner than they would have been normally, preventing an unnecessary hospital admission. And then from the staff in the team, people learn so much from each other. So some of the feedback was it had been a pleasure to work in the team because we learned so much from each other. It's been really lovely to work in this fantastic team. Everyone's been so supportive. And we really felt that that support was definitely needed because we were working in a virtual way. We never actually were in a room together. So to build a cohesive team and get that feedback it's really a lasting legacy for us. And there's a strong will to take the learning from the MDT and to embed it in future ways of working. The system-wide frailty programme that is due to commence is going to support this, and our work will have a lasting legacy. And we got thank yous from all the leaders, from all the stakeholders. And just lastly, a district nurse said, I just wanted to say that I referred a lady into the out-of-hospital MDT and I've been super impressed how quickly referrals and telephone calls were made. This service is wonderful, and I thought I would share some positive feedback on how great a job you are all doing. And that's really all we want, isn't it, from staff and from patients. And that's it, thank you.
Thank you very much. And so if there's any questions, ask away.
Hello again, and welcome to Rachael and Carla, who are joining hear about your work on turnaround and for joining us today for some questions. As ever, send them in to me via swap card. Just a slight warning that Rachael and Carla's internet connection is a little unstable, so it's just possible they may suddenly disappear, but we'll endeavour to get them back as soon as possible or switch to an image rather than video, so we will continue and it will be fine. So as I said, welcome. So a few questions from me to start off with, but audience, please do send in your questions. First of all, have you enjoyed working with colleagues in social care? And I guess I'm asking that in terms of to what degree does this kind of initiative rely on good working relationships?
Hiya. Yeah, we really enjoyed it. This has been it's been highlighted by social care colleagues and by our own as a time where we really have enjoyed working together because we were all there for the same aim. We were trying to support services and patients in a really difficult time, and so each of the individual practitioners, both from social care colleagues and our own, were very cohesive and learned a lot from each other. So yeah, we really did enjoy it. And one of the social work colleagues said within 30 years of practice, she's never worked so well with health colleagues. So that to me speaks volumes.
Wow, yeah, that's a ringing endorsement, I would say. No, that's fantastic to hear. I suppose looking at the positives for patients, have there been? I mean, I don't know whether you would notice that you're in what you're working on at your side, but has the system, for example, seen fewer readmissions and things like that of patients as a result of what you're doing?
I think when we started the service, there was no readmissions for the patients that came into the service. They came home sub-optimised, and because we got as soon as we got the referral, we had a 2-hour turnaround to ensure that we triaged, had an MDT, and spoken to the patient that it was regarding, or their family members. And so because of that, and things were implemented so quickly, we had no readmissions back to the acute trust.
Okay.
It might be important that we're a team that mobilise and demobilise as need requires. So ongoing, we don't have ongoing data for any of those patients. But certainly the ones that we saw during that period of time were no readmissions.
Great, thank you very much. And I mean, I was always going to ask this one, I'm afraid, because I ask most of our speakers it. But what are the main challenges that you've had to overcome to implement the initiative and the changes that you've brought in?
I mean, I think the first one comes from being in the midst of obviously a global pandemic where we couldn't meet as a team. So as previous speakers have discussed, IT was our way forward. So not only were we meeting new colleagues within our trust, we were meeting obviously new colleagues within the social care sector as well. And that obviously poses challenges. But when we came together, we had fantastic team building. So we spent quite a bit of time at the beginning getting to know each other, what our roles were. And I think it just worked really well. I think technology is the challenge. However, as a team, we helped each other day in, day out.
Yeah, we had to be really creative because what we wanted to do was mirror setting up a new team in a room where you would have a coffee and a chat and get to know each other. And we tried to mirror that using MS Teams. Some of the challenges with that were some organisations prefer to use Zoom. Our organisation prefers MS Teams. We were the host organisation because we had all the patient record systems and what have you. So we were trying to involve other organisations using MS Teams. And so it was new for their staff, but also their IT struggled with that. So that posed a real challenge. But as a virtual team, we had to overcome that. So sometimes we had people on loudspeaker on the phones watching the video, trying to marry it all up together, but just so we could get people as if they were in the room together.
Yeah, it's as you say, it's very much people using Zoom or Teams. I can relate to that. Yeah. Okay, so we've had a question in. So this is from Leslie Stanway, and she wants to know, what would you say have been your best wins?
I think working with social care, I have to say, building that, like, I think at the end when I wrote the article at the beginning about building bridges and not barriers, I think it has knocked a lot of barriers down between Bradford's health and social care. And we're not just names, we've got faces to names now, we've got people that we can speak to and get advice from quickly. And there's work moving forward that we've started, isn't there, that we've taken from this team, that we've learned from, and I think, yeah, they're definitely some of our wins.
Definitely. And by having that joined up approach and working alongside not just the social care sector, but also we had allied health professionals, therapy colleagues, we also had personalised commissioning nurses involved. We've now, as a service within existing mainstream services, so the community matron service, we've now got involvement in all of the Actors One system-wide programmes. So we've really created that network, and that's been a massive win. Because there's quite a small team, there's only 40 matrons in Bradford District Care Trust. And so part of being quite a small team, we've now expanded our reach by being part of the out-of-hospital MDT. So now we're involved in system-wide respiratory programmes, cardiology, ageing well, some long COVID work, some pulse oximetry at home work. So we're really involved as a small team, but kind of across a system-wide approach. So that's been a big win for us. The next thing, I think.
Great, thank you. You mentioned long COVID there. Of course, that's something that again, as an emerging area that people are interested in. What's been your experience of that and providing care?
Do you want to speak as a clinician and then I'll come on?
So long COVID is definitely having a massive impact on both the patient, the waiting times. I know that that's just been brought up today in the in Parliament in regards to the waiting times and things, and we're definitely having a knock-on effect. We never sort of use the technology in the sense of triaging as matrons. We still went into the patients' homes, and so we are seeing a massive knock-on effect on both physical health, but indefinitely on mental health as well. And so we're just sort of fighting our way through that at the moment. There is light at the end of the tunnel. And so, yeah, we're just taking it day by day and learning as we go, really.
Yeah, we're looking in as well as part of long COVID in blurring some boundaries on kind of referral pathways and that kind of thing. So we've got the long COVID clinics that we're setting up and the referral pathway. We've got long COVID coordinators now, which the community nursing services will link in with. And we're looking at, as a service, the carers of patients. So it's not just the vulnerable patients that we look after in community that may have deconditioning or fatigue from COVID, but also those carers of those patients who may have had COVID, now, you know, suffering with fatigue and deconditioning and any respiratory problems, that are then caring for our patients. So we're very heavily involved now in kind of looking at how we can support the patients, support our staff in supporting the patients and their carers.
Great, thank you very much. Yeah, very, very interesting topic. I think, as I said, will resonate with everyone. So just turning to staff training, actually, what has that involved for this initiative?
I think, first of all, there was the IT. We needed to get everybody on board with IT, and because all of our work was virtual, any of the MDT meetings that we had, any of the huddles, were all done over MS Teams. So people needed to be aware of how to share screens, how to get system one up so we could go through patients' records. We also needed to have some kind of core competencies within the team because people had come from different areas, so we were sharing knowledge with each other, and we had a Teams area in, chat area in place where you could put resources, and each of the different professional groups would put resources in there. So we had quite a library by the end of the first wave, and then we added to that when we went into the second wave. So the second wave, the focus was more on care homes, so we needed some palliative care input. So they provided some education for the rest of the team to know how to support care homes with kind of the palliative aspects of it, not just the equipment and the processes to get people into what we were calling super rota on the presentation, but also to be able to support the care home staff. So it's been an ever-changing kind of model, really. It's not been a one thing. It's changed with the needs of the patient group. So the first wave was around patients in their own home and how we would all have kind of core competencies in what we were doing for those patients. Then we moved into more of a care home model, and then we needed to, work out what people needed in terms of supporting the care homes through that. One of the things that the care homes were required to do was taking observations for the super rota. So a GP would ring in at 10 a.m. every morning, find out if the patients were well, what their oxygen saturations were, temperature, whether they were eating and drinking, that kind of thing. We then had to provide, as community nursing services, we had to provide some training for the care home staff because we were asking them to do observations, but they weren't all confident in doing that. So we then, as community nurses, went out, community matrons or district nurses went out and did some face-to-face training when they were going in for something else. So a DN might be going in for an insulin injection, but then they do a bit of observation training to support the care home staff as well, which then in turn that supported the out-hospital MDT and the super rota.
Oh, fantastic. In fact, we're just out of time, so that was the perfect point to end on. So thank you very much to Rachel and Carla for their presentation. Yet another great initiative. Right, so next is our final content session of the day, which is our panel discussion on reducing the burden on staffing. Or staff, in fact, I'm sorry.